Hi everyone, this is Elena. Today we'll see the most essential session in the most sensitive the part of resuscitation, which is resuscitation of the newborn baby is very critical because losing the baby after that long pregnancy journey and after that difficult labor process is heart-killing and also devastating to the mommy to lose a baby. So it's very essential to know any students and any professionals working in the labor ward should be familiar with this concept because nobody can predict what's going to happen in the labor ward. So everybody should be ready to resuscitate the baby. So today we'll see about newborn resuscitation. Let's see what's neonatal resuscitation. The meaning of neonatal resuscitation is an advanced procedures which is being done for the newborn babies, where the babies which face difficulty breathing when the baby is out from the womb and when the baby is fail to transit from the mommy's womb to the outside world environment. Some babies get some difficulties to breathe in the outside environment. So helping them for the breathing is essential. We call that procedure like neonatal resuscitation. When we see the epidemiological feature of babies who require this resuscitation procedure is fortunately most babies don't need this resuscitation. That means around 90 up to 90% of, I mean 80 up to 90% of babies just normally breathe by their own selves. So just they simply need a routine assessment and routine birth care. So we only face with little babies, but if we are not acting rapidly and accordingly, we may lose them. Around 8 up to 10% of babies may need to dry, and they need us to warm them for clearing their airways. That means to suction and also to stimulate because they may not be able to breathe at the moment. And around 3 up to 6% only need about bag and mask ventilation, which means that they need us to ventilate them through the baskets, and only less than 1% needs chest compression and medication. This is a very advanced procedure. So only 1% is very sophisticated and need this advanced feature. So simply by warming them, by clearing the airway, and also by simply bagging them will help them to live. So the matter is our fast measures. So we have to be conscious to help the baby immediately. We have to know about how we rapidly assess those patients, I mean, those babies, whether they need this resuscitation or not. So the first one is we have to clearly know that whether the baby is term gestation, which means is the baby is coming at the exact time. Babies that's coming from 36 weeks is considered like a preterms. So most preterm babies are considered like they may be face to difficulty of breathing, so we have to ready for them to resuscitate. And the other one is whether the baby is crying or breathing. If the baby is not crying or is not breathing, definitely they need our help. So we have to be ready for resuscitation. The other one is checking the good muscle tone. Limp babies or the babies that do not have a good muscle tone or activity, they are limp, so we need to resuscitate them. And the other one, skin color is also very essential, which means checking the skin color with whether it's pink or it's bluish, which is cyanosis. Pink babies are fine, they don't need our help. But skin color with the bluish discoloration is the sign of depleted oxygen levels. So, especially central cyanosis is a good indicator for starting of neonatal resuscitation. Sometimes peripheral sign of bluish discoloration may be considered like normal, but we have to be focused on the central cyanosis as well. Why do some babies need our help? Why babies are difficult to breathe pausals when they are out from their mommy's womb? The first one is asphyxia. It's the commonest one. That means when the baby is aspirated or asphyxiated when it's inside the mommy's womb, which means the baby is gonna drink or aspire to their respiratory tract, commonly the amniotic fluid. This will be happen when the baby is facing a stress situation. The other one is prematurity. As I previously said, that prematurity is the good indication for the resuscitation because their lung maturity cannot be well, so they may need our help for resuscitation. That means that they are unable to breathe by themselves due to lung prematurity. The other one is sepsis. It's an obvious when the baby is in a septic condition or when there is a septic environment, they are become unable to breathe by their own selves. The other one is congenital malformation when the lung and the cardiac system not work perfectly developed, the babies will face to the breathing difficulties. And the other one is intracranial disease. Since our brain is the breathing control center, if there is some kind of problem in the baby's brain, it will be difficult to cope up with the good breathing efforts. And knowing the equipment is also very essential. The first one is syringe bar. It's a very simple, it's very important equipment in the labor ward that is used to suck out the any suction the fluids from the baby's mouth and also the nose. And the other one is bagging a mask. When the baby needs our bagging support, we need the bagging the mask equipment. And the other one is oxygen source. During the resuscitation, always have to focus on the breathing tendency, on the oxygen saturation, and also the heart rate status. So oxygen source is also needed. So we have to provide the baby as some scenarios to cope up with this breathing problem. And suction catheter is also essential when the baby is not be well cleaned with that syringe bulb, as mentioned in the above. We may need to suction catheter to suck it from the upper part of respiratory tract and sometimes to the down part. So suction catheter is also essential. Medication is also important. So the procedure of this resuscitation, we may need some medication if the baby is not revived through an oxygenation and also through the positive pressure ventilation and also through the chest compression. We may use some medication which is commonly epinephrine. And also after those compression medication and also just compression in the back ventilation, we may need to challenge them with fluids commonly during a lactate and normal saline when we see the sign of shock or hypotension. Endotracheal tube also sometimes essential because we may intubate the babies through these procedures if we do not see any improvement or a successful resuscitation. The pulse oximetry is also essential since we are following the breathing tendency. Knowing the oxygen saturation is also important, and flow is very important because every step in the resuscitation should be done very rapidly, which is everything, the assessment and also the measurements also be done within 1 minute. So clock is also essential to see our speed. Okay, which baby needs for resuscitation decision? When the baby is crying, no need for resuscitation, no need for also suction. So if the baby is crying or if the baby is well breathing, we have to give the baby to the mommy to start skin to skin contact and also for initiating breastfeeding. And if the baby is not breathing, but if the baby is not crying but still breathing, that means when the breathing is 30 to 60 minutes, so we don't need any resuscitation or and sometimes we may need suctioning to clear out some minor aspiration. But if the baby is gasping, definitely we need to start resuscitation immediately. And if the baby is not breathing at all, we have to start resuscitation immediately. Those are the scenarios to differentiate the babies which needs resuscitation and which one is not. Let's see this algorithm. This is all about the mental resuscitation steps. And we see the time around which is one on the left. Everything should be done within the first 1 minute. And the first second is to assess whether the baby is needed the resuscitation or not. The first of all, when the baby is a term baby, and if the baby is breathing effectively, and if the baby is crying or the baby got a good tone, we don't need any resuscitation. We just give the baby to the mommy to start the routine call, which means breastfeeding initiation and also to keep up his temperature, skin to skin, such other things. And if the baby is not term, and sometimes if the baby is not breathing and also the baby is not breathing, you have to help them. The first step is like starting with stimulating the baby and also drying, clearing the upper airway, sectioning the mouth and the nose, and stimulating. That will help the baby. If we gain the baby or if we gain the breathing of the baby at this moment, we just give the baby to the mommy. But still, if the baby's heart rate is not good and if the baby is in apnea mode or still gasping or still he face or the baby face some difficulties, we have to start positive pressure ventilation and we have to monitor the baby with a spout, which is the periphery level of oxygen saturation. After that, we may gain the baby. If the baby can start breathing by himself, then we pass the baby to the mommy as following the routine care. But still, after positive pressure ventilation, still if the baby's heart rate is below 100, we have to ensure the baby's ventilation through intubation, and we repeatedly check him. If we gain him, we pass the baby to the mommy. Our cardinal measure is a heart rate during this resuscitation. We keep checking the heart rate. If the heart rate is becoming below 60, that's very serious. So we are just losing the baby. So we have to be act rapidly and accordingly. So we have to start chest compression in this scenario. During the chest compression, we have to cope up this procedure with bag valve ventilation. We bag the patient, we will start the compression, and so we have to be doing these things very rapidly. After the chest compression and after the bag valve ventilation, if still the heart rate is below 60, we have to start to give the medication, which is an epinephrine. And still that, if we still not gain the baby, we have to try or challenge the patient with the epinephrine medication. Still, if you not get the baby, the fluid is also advised because the baby may be in shock. So to challenge this hypotension, we try lactate or normal saline. That's in all procedures we were seeing about the routine care. Immediately after the baby's born and after every resuscitation procedures, if we gain the baby and if we see the baby is breathing effectively, we have to dry the baby to keep the temperature, and we have to pass the baby to the mommy. This is the trust bulb syringe. It's a very important equipment for the babies because most babies will start breathing after we suck out their fluid through the mouth and the nose. And this is the perfect position during the resuscitation because the babies have to be nose up, which this position is called sniffing, because anatomically babies' upper respiratory tract length is very short, so you have to be sniff the baby to gain exact entry to the baby. I think this topic is very interesting. Next time we'll see other advanced resuscitation protocols for like other pediatrics. Thank you for watching today, and thank you so much.